Welcome to the very interesting session, that's cataract surgery, target Emmetropia. So all we know that cataract has become now a refractive surgery. Patient wants the very best. They want to have 6 by 6, n by 6, maybe on the second day or the next day. Thanks to our enterprising surgeons, LASIK, laser, and so many things have been hyped there. And patient wants the very best. The question is, are we ready for this challenge? So this session is going to be talk about this various nuances of these things, how to achieve perfection in your cataract surgery. Before we start the session, I would like to introduce my faculty, which is very renowned one. Dr. Pupil, please join us on the dais. There's some technical problem they are adjusting. So I was just talking about the cataract surgery. You know, it's quite cataract refractive surgery. So we have to look from the basics to the end and how to manage the surprise also. So our talk will be divided like what you have to do in preoperative period, how to examine the patients, what are the fine nuances. Then during the operative procedure, before operation, you have to select how to choose the best IOL, how to do the good biometry. Then during IOL, what are the things which you can improve your results with? And you did everything best and still something goes wrong. You got a surprise. And that can happen even to the best of surgeon, best of the prepared patient. Even in the simplest case, where everything is normal, suddenly you may get a surprise. So that's not uncommon. How to manage this surprise now? Our first speaker is Dr. Vipul Arora. He is Director Vedanta Jyoti Eye Hospital, Roorkee. He was trained at Arvind Eye Hospital, Madurai, under mentorship of Dr. Usha Kim. He further did his ICO in oculoplasty fellowship from New York and Eye Infirmary. His was observership from Columbia University, New York, under Dr. Michael Kazin. He was a FACO instructor for ICO fellows and worked as a consultant at Mahatma Eye Hospital in Nagpur as an assistant professor at MGIMS, Varda, for teaching undergraduates and postgraduates in ophthalmology. He has many academic laurels to his credit. His excellent surgical skill and technique has been instrumental in giving sight to many people. He has also published his scientific study in various peer-reviewed journals. He's always enthusiastic about getting the newer technology in his practice to provide his patients with best of his possible care. So, you know, Roorkee is a very small place, but he's a very big surgeon there. So, Dr. Vipul Arora will be speaking on risk factor and pre-operative assessment. I think this is the most important if you're going to start your refractive cataract surgery journey. Then we have with us Dr. C.M. Wavekar. Everybody knows him. He's a medical director of Vavekar Institute. He is managing trustee at Shri Indra Bhai Wavekar Charitable Trust, principal and director at Wavekar College of Optometry. He's a trustee at Janardhan Charitable Trust. He's a co-author of Wavekar and Saurabh Toric tool, which both of us we have here. And he's one of the earlier user of Flex. So we have a lot of his things to his credit, and he'll be speaking on accurate biometry. Then we have Dr. Rajendra Prasad. He's vice president of DOS. He's director and consultant ophthalmologist at RPI Institute and research center Vasant Kuch, New Delhi. He has won UKSS gold medal in 2017, IIRS gold medal in 2017 again. He is won the Indian Inventor of the Year award from UPSS, Innovator Award at Expert Conclave AIOC 2018. His various techniques are very popular now, like terminal chop technique for very hard cataracts, swing needle technique for wide cataracts, then Terminator, the wedge tool, hydrodissect for PPC, and T-soft for soft cataract. He's popularly known as Terminator because of his invention. So Dr. Rajendra Prasad will be speaking on surgical refinement, how to improve your incision, IOL placement, toric IOLs, multifocal IOLs. So how you can get a better result in these conditions. Then me, it's a little immersive, but I'm a president of IIRSI. I'm past president of Narzun Optical Society, chairman of Scientific Society of UKSOS. I won the best paper award at DOS in 2000, then gold medal at 2017, IGO Honor Award for peer review this year only, and chairman of Navjyoti Eye Hospital at Dehradun. So I'll be speaking refractive surprise management following cataract surgery. And we have with us Dr. Pooja Kumar. She'll be joining now. Recently, she's another session. She is currently a consultant and head trainer at Cataract and Refractive Surgery at Narayan Nethralaya Eye Institute. She is actively involved in translation research and as a clinician and translation scientist with CRO and IBMS lab. She has done her PhD in wound healing of refractive surgery with Maastricht University at Netherlands. She has pursued her fellowship in cataract and cornea and refractive services from Narayan Nethralaya. She is also the editorial board of Journal of Refractive Surgery, Journal of Refractive Surgery case reports. Her areas of work include wound healing in refractive surgery, customized laser for refractive surgery and keratoconus, AI for refractive surgery, gene therapy for corneal ectasia and keratoconus, neurotherapeutics and corneal scar and management, immune profiling for keratoconus. Her philosophy for life is take a chance. You never know how perfect something can turn out to be. Dr. Pooja is going to speak on happy surgery, unhappy patient. You did everything well. You are very, very happy that everything went well. But patients say, Doctor Sahab, maja nahi aaya. And you see, maja nahi aaya ka matlab kya hai? Then you keep on wondering what patient want to say. Then we have a keynote address, which is an assignment to our course. We have with us Dr. Saurabh D. Patwardhan. He is director, Nandeep Eye Hospital and PG Institute. He is head FACO training and fellowship program. He is a chief mentor on FACO Tips 3D teaching course. It's first kind of this thing in the world. Pioneer in live streaming of the surgery on YouTube and Facebook for education. You might have seen on the YouTube a lot of videos he has posted. More than 10 publications, more than 30 chapters in various books and journals. He is the inventor of a Toric Patwardhan Android phone-based toric marker and a hybrid chopper. 3D surgical viewing system also. Runs popular FACO teaching at YouTube channel and also teaching website is www.facotraining.org.in. He's performed more than 50,000 surgeries. His specialties include cataract, retina, glaucoma, refractive surgery. So practically whole the eye. Performed live surgery in various conferences. He is ex-member of Scientific and Managing Committee of MOS. He's invited faculty in national and international conferences. Dr. Patwardhan, you must have seen on the YouTube's there's a channel there. You can go see a lot of interesting teaching videos are there. You'll enjoy seeing them. Thank you. With this, I think Dr. Rajendra Prasad has to go first. He has another session. I'll invite him first, just out of queue.
Good afternoon, friends, ladies and gentlemen, and chairpersons. Thank you, Dr. Vinod, for giving me this opportunity to be here with all of you in this beautiful evening. And the topic, what he has asked me to talk on is surgical refinement, incision, IOL placement with toric IOL and multifocal IOLs. We do not have any financial interest on the subject matter of this presentation. Friends, you know that in cataract surgery, almost 20% of the patients, they have astigmatism of more than minus or plus 1.25 diopter. And implantation of the simple spherical monofocal IOL lens require a distance near and astigmatic correction for clear distant vision along with the astigmatic correction. If you are coming across with the patient with the astigmatic problem with the cataract. So we have various options starting from the glasses, corneal surgery, post-op laser procedure or toric IOLs. But in our clinical practice, I think the toric IOLs gives you the best result out of any of these techniques. But the only thing is with toric IOLs, your surgical procedure or the surgical steps has to be very, very accurate, starting from the incision, marking of the IOL axis and placement of the IOL, your Capsulorhexis, and each and every step has to be accurate and correct. Now, this particular case, what I'm trying to do is I'm marking the axis, and after the reference mark, which I have already done on the slit lamp. And this is what I do normally, because when I do a mark, I give a mark on the cornea also with a linear cut, which is visible then throughout the surgery, because many times this junction violet mark would disappear during the surgery and when you are cleaning the anterior surface of the cornea. The incision, giving the main incision is very important, because either you give it on the steeper axis, or if your calculation of the axis and the amount of the astigmatism is done according to this. And if not, then you can give at any part of the cornea. Capsulorhexis is very important. You have to get an accurate and well-centered capsulorhexis of accurate size. This is very important, and your rhexis has to be regular. And any situation, if your rhexis goes out of its continuity, then it's always better to go in for the normal or the spherical IOL instead of going for the toric IOL. Now, this particular case, as you have seen, I've got a beautiful rhexis at the center of the lens, and then your rest of the steps of the phaco-cataract surgery is usual standard steps, like you go in for the chopping technique, or you can go for stop and chop, whichever technique you like to do in a particular situation. And once you remove the nucleus, your cortical removal and the epinucleus removal is important. And the most important part is, like, you need to have a clear capsular bag. That is very important, because and your posterior capsular polishing and the removal of the whole fibers or any kind of debris which is there on the capsule has to be well cleaned. And as you can see here in this particular case, I'm trying to polish you can see these fibers, so you should not leave these fibers. So you must remove everything which is visible there on the capsule. And a good polishing is very, very important, because in any premium IOL, you need to do a good capsular polishing, and you should never worry for cleaning the capsule, because it's very simple, and the capsule will never come on the aspiration port if your the opening of the port is upside. And this is the inflation of the capsular bag with the, and this is the toric IOL I'm going to put in. This is Technis toric from the J&J, and very easily it goes into the capsular bag. It's a hydrophobic IOL, and try to use always hydrophobic, because you do not want any kind of posterior capsular opacification in these cases. And your positioning of the IOL is quite important. As you can see here, you have to place it within the bag, and the axis mark is there on the IOL, just adjacent to the haptics. And your removal of the viscoelastic is also very important, because you need to remove the complete viscoelastic. But these days now we are doing the hydro implantations, so this step can be avoided, especially in toric IOL. But this is an old video, so I'm trying to remove the visco even from behind the IOL. So you need to remove the visco from behind the IOL, also very important, because otherwise if you leave the visco behind, then the IOL may rotate. So this is what I'm trying to do, because I'm trying to clean the whole visco from the bag. And then you have to tap the IOL a little, and then position it, align it with the axis mark. So you can leave a little bit of, now you can see, because here I have already aligned it very well. And now this can be confirmed with the alignment mark which is there on the microscope. And you can see now the IOL is well aligned and at a fixed axis. So this is very important, because you aligned it well, and then hydrate the wound so that your anterior chamber is tight. Never leave the anterior chamber loose, and any kind of evacuation of the fluid may rotate the IOL. So these are the important steps in the surgery. And if you have to go in for the multifocal IOL, then you can use this multifocal toric IOL, because the patient now these days have started asking for the multifocality. And this is the multifocal toric IOL which I'm going to implant in this. But the rest of the steps are same. The only thing is, because if the patient is asking for the multifocality, then you can go in for the multifocal toric IOLs. So surgery, as I have said already, the standard steps are followed in any phaco surgery, and your final toric marks have to be well aligned with this is the important which you need to check on the first post-op day also. If any kind of misalignment, then your the alignment or recorrection has to be done as soon as possible. Now, an important point is your during the calculation, your SIA calculation is very important, because SIA is the amount of the astigmatism you leave into the cornea with your corneal incision. So this would vary from surgeon to surgeon, and there is a online calculator, so you can calculate your SIA with this online calculator, and accordingly you have to give the feedback to the person who's calculating your final power, or you have to feed into that. So various these toric IOLs are available with various range. Technics has almost, I think, minus almost 4.5 diopter, 4 diopter, which corrects around 2.75 diopter of the astigmatism on the cornea level. And Acrisoft has 6 diopter of astigmatic IOL. There is toric IOL, toricity, and Acryl, this is from Biotech, and this you can have a customized toric IOL made with them with very high astigmatic power also, say up to minus or up to 10 or 15 diopter also many times. The classical success would depend on the good patient selection. The good patient selection means like you need to select a good patient for the toric IOL. It has to be a regular astigmatism. Minimum astigmatism, which we actually look for, is plus minus 1.25 diopter. And your cataract surgery has to be uncomplicated. Preoperative measurements of the astigmatic power is very important, which can be done with the keratometry. Like you have various, it's always better to do a multiple keratometry machines you can use if you have. Otherwise, a simple manual keratometry is also very good, because this gives a very good, accurate result. The reason for that is because it's going to measure a little larger, wider area of the cornea rather than these optical biometers or keratometers. This is how you can see here, because the manual keratometer measures almost 3.2 millimeter of the cornea, and this optical one would measure 2.5 millimeter. And you can use Placido topography to measure the astigmatic power. And the important point is, like, you have to, because these days we are using the IOL calculator or the calculation formulas where you need to incorporate the posterior corneal astigmatism also, and this can be measured with the topography maps also. And the next important point is biometry, because I'm not going to speak on this, because Dr. Vavikar is going to speak on this, so I'll just leave it. And IOL calculation formula, you have various formulas, but you need to look into the formula which fits into that particular patient. But these days we are using Barrett's Universal 2 formula, which is very good for the astigmatic power, and Hill RBF is also good formula for the astigmatic correction. And these are the parameters you need to feed into the calculator. And before we calculate the axis marking, before we start the surgery, the axis marking is very important, because we need to do a good the reference mark on the cornea or on the sclera limbus. These are the machines, the devices we can use for the marking, but what I prefer is the slit lamp marking is very good, because if you are positioning the patient properly on the slit lamp, so you can mark with the slit lamp that reference marking. And I will not go into the detail, but the Varian is, we all know the Varian gives you intraoperative help while marking the cornea and putting the IOL and placement of the IOL. The important point again, which we normally miss, is the marks which is there on the lens. It has to be aligned with the steeper axis of the cornea. So that is very important, because the IOL power is on the perpendicular to the mark. So the mark has to be aligned with the steeper axis of the cornea. So to conclude, any kind of irregular capsular axis, as I said in the beginning, avoid putting the toric IOLs, and especially the zonular integrity and the capsular integrity is lost. And anterior chamber depth consideration is very critical. in getting the accuracy of the toric IOL. So I think I'll just finish it here. Thank you very much.
Thank you so much. It's a beautiful presentation, Dr. Rajan Prasad, and we'll keep on discussing. I know you got a lot of questions, but that will be repeated in next subsequent sessions also. So let us finish the session, or maybe in between we can say. And now we have the keynote address with none other than Dr. Saurabh Patwardhan. He's going to speak on physics behind extending Capsulorhexis. So here comes the physics. Meanwhile, I think Dr. Rajan Prasad has very, very important point. If you are going to mark your toric, you are using a gentian blue violet pen. Sometimes what happens is not 1 or 2 or 3, it gets smudged all there. But once you use a needle over it, that will stay there. That will not be during the whole surgery. Even the gentian blue may wash away after some time. So that's very, very important to align yourself. And slit lamp is very easy to use for toric lenses. It can be, I'm just going to learn. Toric is basically a separate chapter. Otherwise, there are a lot of tips for toric lenses, how you can do it simply on a slit lamp or using your smartphone. That's very, very easy.
Okay, thank you so much, sir, for the kind introduction. And this is a keynote address. So basically, it is not part of the instruction course, but I would say that good Capsulorhexis is the initial step for achieving Emmetropia. So maybe that can be considered in that way. So I'm Dr. Saurabh Patwardhan, and my interest is in teaching, and I try to devise techniques to teach my students and fellows. So in this talk, I'll be speaking about the physics, the knowledge of physics, how it helps in doing a good Capsulorhexis. So the first important thing which we have to look at is the intraocular pressure, because once we open the anterior capsule, we must understand that cornea is open and now the anterior capsule is open. Then the intraocular pressure, if it is high, it is going to cause extension of the capsulorhexis. Now these are few conditions where intraocular pressure is high, but few things which might be missed when we are doing the surgeries, like tight speculum, tight orbits, and also the raised intraorbital pressure because of peribulbar block. Many times we give peribulbar block and take the patient immediately for surgery, and we miss out on these points where the intraorbital pressure leads to intraocular pressure. And even if we are going with a good capsulorhexis, sometimes it just starts running out because the intraorbital pressure is high because of the preoperative peribulbar anesthesia. Another thing which we must notice, that every patient's eye is different, and that difference is mainly because of the scleral and zonular elasticity, which is variable. So elastic sclera is commonly seen in young eyes, like pediatric eyes or young adults, also high myopes, and these behave differently. So in these eyes, what is different is that not just the shallowing of AC, which is seen commonly causing the capsulorhexis extension, but even the increased deepening or excessive deepening of the anterior chamber can also lead to capsulorhexis problem. I will show you a very interesting video about this. So just watch here. The capsulorhexis is going fine, and the surgeon just inflated the anterior chamber too much with HPMC, and just the capsulorhexis just went out. Many times this is not seen because the pupil is not well dilated, but you might experience this in your surgery where you feel that you have done nothing wrong, but it was an excessive deepening of the anterior chamber which might cause capsulorhexis extension. So I think this is a new thing you must understand when you are doing. So anything in excess is not good during cataract surgery. We have to maintain the anterior chamber in its normal anatomical position as far as possible. And this happens because of the overinflation of the anterior chamber in eyes with elastic sclera. So in this situation, what should we do? We should rather use heavy dispersive OVD rather than using HPMC to inflate, because what the HPMC does is that it inflates the anterior chamber rather than putting the weight over the anterior capsule. So rather use a heavy OVD which puts the weight on the anterior capsule without extension or expansion of the anterior chamber. Another thing, it's important to understand the anatomy of the anterior capsule. So if you see, normally the 6.5 millimeter and beyond is the area of zonule. So your capsulorhexis should be within the 6 millimeter area. And in some cases, there might be long anterior zonules which you have to observe during the surgery. So always make sure that this capsulorhexis never extends beyond the 6 millimeter area. So the aim should be 5.5 millimeter, because once you go beyond, like for example, this particular trainee was doing capsulorhexis, he felt that he was going fine. But if you see the actual anatomy and actual size, he was way beyond the 5.5 millimeter mark, and now it was going into the zonular area. And zonules, what they do is that they pull this capsulorhexis margin outwards. So obviously a good going rhexis suddenly went into zonules. I'm sure that many young surgeons have faced this and they feel that everything was going fine. Why this happened? Another thing which you may notice in some cases is that the anterior capsular surface is very convex, and that leads to more outward force. So in such cases, if you go beyond 5.5, you will find that there is significant outward movement of the capsulorhexis tear. It happens obviously in intumescent cataract, but also happens in small eyes. So when you see a convex surface, I just wanted to show this particular test which I use for intumescent cataract. I call it Visco press test. So what is Visco press test? Once you, I'm sorry. So once you put the OVD, how to, okay, pause it. Okay. So once you press the, I'm sorry, I want to show you this. Okay, once you put the OVD in the anterior chamber, just look. In 3D, you can appreciate it better, whether the anterior capsule is flat or not. If anterior capsule is flat, then what happens is that there is no outward force on the capsulorhexis margin, and then you can have very easy capsulorhexis. You can just remove the intralenticular pressure and you can go ahead. But even after putting OVD, if you find that the anterior capsule is too convex, in such cases you have to be more careful. That indicates that the intralenticular pressure is really high, and these are the real intumescent cataracts. So just remember this Visco press test when you go ahead in your OT next time. Another thing, how to take this extending capsulorhexis inside. So it's important to understand the vectoral forces here. So this is the area of zonules. As I already told, that zonules are going to pull this capsulorhexis tear outward. Okay, this is the force which the zonules are going to apply. So in order to negate this force, you have to either do completely opposite way, that is pull it centrally, or the Little's maneuver way, that is pull it unfold the flap and pull it other way. But what happens commonly is that you tend to, one second. So what happens commonly is that instead of pulling it centrally, you tend to pull it tangentially, as is your natural, the pull, the tangential pull, and it leads to further extension because the resultant force is outward, it's not inward. Same thing, excess OVD injection, I already showed it. And the second thing, important thing, is the pull has to be quick. Most have happen, what happens is that you are hesitant to pull the capsulorhexis in. When you pull slowly, in fact, the vectoral force is still going outside, and that's why when you pull slowly, it still goes out. And I will just show in one of the videos. So you have to make sure that a resultant vector is not outward, but it should be completely inward. Okay, so let me just show this video. Just watch this. Capsulorhexis already into zonules, and now when I pull it slowly, it still goes out. But when I pull it with quick maneuver, it comes in. So the vectoral forces are being changed here by quick pull centrally. So this is very important. Most problematic thing is that you are hesitant to pull it quickly and centrally. So make sure next time if it is going into zonules, here the pupil is well dilated. Still, you can see from the zonular area, I can just pull it in even when the the zonules are still attached to the capsulorhexis tear. This is a very important trick to have, and with this trick, you will not never have extended capsulorhexis, because you can pull it back even from the zonular area. So understanding physics makes you understand the response of ocular tissue, which is very important when you are doing surgery. So thank you so much. Hope I was quick. I wanted to make sure that you get enough time for the instruction course. Thank you so much.
Thank you so much. It's a very excellent presentation. I think the things what we do won't understand also, but how it works, that make us to make our surgery better if we understand the basics of these things. Thank you so much, sir. And starting with the basics, we are going to have the next topic is risk factor and preoperative assessment by Dr. Vipul Arora.
So, good afternoon, everybody. At the outset, I would like to thank AIOS and Dr. Vinod Arora, sir, for giving me this opportunity. I shall be presenting my talk on risk factors and preoperative assessment for emmetropia and cataract surgery. I have no financial disclosures for this presentation. I shall be focusing on the following points in my presentation, starting with patient counseling, ocular and systemic examination, ocular surface and dry eye disease, followed by biometry and astigmatism, coming to newer modalities, fundus examination and OCT, and lastly, risk stratification system. Everyone wants perfect vision from cataract surgery, but we should try to keep patients' expectation at practical level and follow the mantra of under promise and over deliver. Whatever we do in cataract surgery, there is always some level of compromise, as we still do not have a perfect IOL that matches natural lens of a 20-year-old patient. So it is our job to figure out which compromise suits best to the patient. If we look at the benchmark standards for cataract surgery, we see 55% of patients are within half a diopter of target and 85% are within 1 diopter of target refraction. That leaves about 15% of the patient that are still outside 1 diopter of intended target, so there is room for improvement there. Generally, every hospital has team of preoperative workup which consists of optometrist, counselor, PRE apart from operating surgeon. Every patient who has come for cataract surgery also need a dedicated time and attention to know the expectation and lifestyle of the patient and also to make him understand what is best that can be offered to him. In examination, like always, as most clinicians will do, always examine both eyes at same time. It should not be only for visual acuity, but also for all parameters at same time. We should we should also not forget to take history of any prior ocular surgery or any history of blunt trauma to avoid any surprises during surgery. Preoperative evaluation begins with good history taking. History of drug tamsulosin, which is an alpha blocker, can cause floppy iris syndrome. Aspirin and warfarin can be continued if INR is in therapeutic range. Apart from routine blood pressure and sugar, we check ECG and oxygen saturation for all patients of cataract surgery. Viral markers are must for any surgical procedure. Latent tearful examination is most underrated examination in cataract surgery. A study by Lucas et al. Have shown 59% of patients posted for cataract surgery had blepharitis. We should always try to look for any stye, lesion, or lid retraction in the eye, and should also examine the tear film by tear film breakup time or Schirmer's test. Good slit lamp examination is cornerstone for cataract surgery. It helps us to rule out any other ocular comorbidity and also help in making risk stratification plan. It helps to preempt any intraocular complication during surgery and be better prepared for it. Spend few extra minutes to look for any corneal scar, prior LASIK or RK cuts, corneal gutted, fine old KPs. Size of pupil is important, then grade of cataract, whether it's a posterior polar cataract, subcapsular cataract. It helps in managing the case more efficiently. We'll talk about fundus in next few slides. Dry eye is almost everywhere. It is one of the most common thing that we see in our general practice, but sometimes we are so focused on cataract that we might overlook this issue going on in our patient. This can be debilitating condition for many patients and it really affects our outcome. It is really frustrating for a surgeon and that after doing a perfect surgery, patient is 6'6", they still feel that surgery is a failure because they are struggling with irritation and dry eyes after surgery. They consider it as our fault as this irritation was not there earlier. There is a landmark study called Prospective Health Assessment of Cataract Patients' Ocular Surface, or popularly known as FACO study, that looked into the incidence of dry eyes in cataract surgery. In this study, 63% of patients had tear film breakup time of less than 5 seconds. 77% had positive corneal staining. Schirmer's score was low in 21.3% of cases. And only 22% of these cases carried an established diagnosis of dry eyes. So, still 78% of the patients are undiagnosed case of dry eyes who presented for cataract surgery. There is another study by Dr. Priya Gupta regarding same, and they have found that 57% had abnormal osmolarity in tear film and 40% had positive corneal staining. We have lot of different tests to assess ocular function. It's better to be consistent with one or two tests and do it regularly in all the preoperative patients screening along with clinical examination. There are a lot of different symptoms that patient can manifest in many different ways for dry eyes, which we see here. Standard patient evaluation of dryness questionnaire, or the SPEED test, as popularly known, it's a modification of ocular surface disease index questionnaire, and it's a way of knowing the status of ocular surface. We also have to take into account ocular and systemic medications and systemic conditions that can impact the ocular surface. Mammography is a new and efficient way of detecting and treating mammalian gland obstruction in patients for cataract surgery. Like in this example, we see a 68-year-old female with history of dry eye disease and LASIK surgery who presented for cataract evaluation. Her dry eye disease was causing poor quality of topography, irregular Myers, and also astigmatism of a pseudocylinder of around 2.37 diopters. But after treating the dry eye disease, the topography showed more regular Myers and there was resolution of pseudocylinder. So, a bad ocular surface can lead to unreliable biometry, foreign body sensation after cataract surgery, chances of infection, and delayed rehabilitation. A tear film is the most important refractive surface. Optimizing it leads to more accurate measurements, more predictable healing, and overall improved outcome. Treatment is by thermal pulsation, immunomodulators, lid scrubs, but we should remember that we should delay the surgery until the ocular surface is stabilized. Specular microscopy should be done when we suspect clinically poor endothelium. There is a risk of corneal decompensation when the count is less than 1000 cells per cubic mm. Coming to biometry, its a topic will be separately covered. I will just highlight few important points. We all use immersion biometry in clinical practice, and it's an excellent tool to calculate IL power in normal range of axial lengths. And this has also been proved by studies. But since all the major guidelines on cataract now recommend optical biometry as a method of choice, but as it is a method of choice, it is helpful tool for refractive cataract surgery. It gives refractive axial length as it measures the center of macula. It also incorporates the actual thickness of retina. It is operator independent, repeatable, and precise. However, like in cases of dense cataract or where patient is unable to fix, we may need to go back to immersion biometry. It's based on optical biometers are based on various principles. Most commonly being used is swept source OCT based, and there are newer advances in this. Third generation formulas are used with immersion biometry, whereas fourth and fifth generation formulas are used with optical biometer. But if we want to use a fifth generation formula with immersion, we can go to various websites like ASCRS websites, which provide free calculation on these formulas. Another important aspect is astigmatism. 47% of cases who presented with cataract surgery had more than one diopter of astigmatism. There are multiple ways in which key reading can be taken, and there are additional topography is also available if we are not unsure, if we are not sure about the axis. I usually take an auto K reading and confirm it with an optical biometer, which is more reliable than above. To confirm the axis, or in case of any doubt, one can use a pentacam. I usually refer my patient to my colleague if I have to use so. Coming to newer modalities, to further refine our results of refractive cataract surgery, multiple machines are available, and in industry we realize that there are so many diagnostic machines, and all trade fairs are completely full of newer machines. Now it lands on to us to understand which works best for us. In this, there are two, like corneal topographer and corneal tomography. Corneal topography measures the anterior corneal surface like OP scan or NIDEC OPD scan, whereas tomography is a 3D image of cornea, and it measures the anterior and posterior surface like pentacam. The major use of topography is in refractive surgery, post-surgery astigmatism, surgical planning in cases with astigmatism, and also incision planning sometimes. These topographers again are based on various principles, most commonly used being Schemfeld based principles like pentacam or hybrid topographer or OCT based topographers. Abrometer is another investigation that has gained attention, especially in premium IOL practice. It measures the higher order aberrations of cornea as well as of whole eye. It is also useful in dysfunctional lens syndrome as well as to measure angle alpha for multifocal IOLs. So, if we have a high volume cataract practice, we should go with either a topographer with the abrometer like OPD3 scan or iTrace, or we can go with topographer and a biometry like Anterion or a Pentacam AXL. Dilated fundus examination with high specificity but low sensitivity, and it is considered standard of care for macular evaluation before cataract surgery. In presence of cataract, its sensitivity reduces, so we cannot diagnose properly all the cases. And so is OCT helps us in these cases, but currently it's not used for all the cases, and it's only used for premium IOL practice. In a recent study by Will et al. In JCRS 2021, macular pathology was detected in 40.6% of cases who had a normal fundus, normal macular in examination. And out of these 26% cases, the management was modified and in the form of intravitreal injection, laser or surgery before cataract. Like in this example, we have vitreomacular traction, but again, the clinical examination fundus is normal. OCT shows VMT. In this case, in a high myope case, there is flattening of foveal contour, foveal thinning, but again, fundus is normal. And in this case, we have a mild ERM. So, the role of OCT is to detect overlooked macular pathology and better assessment of macular abnormalities. It helps in a better informed consent process and realistic patient expectation. B scan is done when we cannot visualize the posterior segment in dense and mature cataracts to rule out RD, vitreous hemorrhage, intraocular foreign body. Coming to last, the risk stratification system. It's a very good tool if incorporated in one's practice. It is especially helpful in meaningful counseling and what to expect after surgery. It also helps to alert regarding unusual intraoperative events and allotment of cases in teaching hospitals. Again, in this case, a study by Muntasib in BMJ 2004, it's a landmark study for risk stratification. And these points are allocated to risk factors depending on weightage of each risk factor in peer-reviewed literature. There are three categories allotment of the points or score per risk factor. Like in category B, each thing earns 1 point, whereas in category C, it earns 3 points. And so, based on the cumulative score, surgical patients is grouped into one of the four groups. Group 1 having no risk factors and group high risk factors. So, the complication increases from group 1 to group 4, and overall complication rate in group 4 is much more. And so, to summarize, a systemic and comprehensive examination consists of patient counseling regarding realistic expectation, identifying ocular comorbidities, a precise perfect biometry, appropriate incorporation of neurotechnology, and developing a risk stratification system. And it helps us achieve not only 2020 but a 20 happy patient. Thank you.
Thank you so much for an excellent talk, Dr. Vipul. I think there's, I can't say there's, one has to do the thorough examination. That's a must for systemic and eye also. And going next to is, you have to have accurate IOL power calculation. That's the backbone of cataract refractive surgery. And on this accurate biometry, we have none other than Dr. C.M. Wavikar with us. Dr. Wavikar is an authority on biometry. He'll be giving us a lot of tips. So I think Dr. Vipul made a valid point. You have to look for the ocular surface first. That is not to be neglected. You have to look for the comorbidities also. Because nowadays, we are not getting patients who don't have comorbidity. Getting a clean cataract case is becoming rare these days. Most of the patients have some sort of problem. They are taking some medicines or something. So we have to have a very good history of whatever is a systemic illness, what the medicine is taking, any family history. Like these things, we have to do a thorough examination of the face, eyes, and fundus also. Whatever the instruments you have, it's good. But even with minimal instruments, you can do a very good evaluation of the patient. Even with a simple slit lamp or even with a simple keratometer, you can give accurate results. Most of the biometries now are available. The IOL calculator, they are available online also. So you can use a simple biometer also to get a good result with these conditions. So over to Dr. Wabekar.
Thank you, Dr. Arora, for the introduction and giving me this opportunity. And good afternoon, friends. So the most important point about accurate biometry is any instrument is as good as the person behind it, and any team is as good as the captain or the coach behind the team. At the beginning, we need to understand that both surgeon and patient want Emmetropia today, and we are very much lacking as compared to LASIK. And therefore, what is to be done is we need to reduce variables. And so, let us divide this lecture into two: the general principles and the specifics. What is the role of the surgeon? He is the guiding start, but not at a distance. Where is the pointer? Yeah, but he's not a from distance. He has to get involved in the process, setting standards, training, and close monitoring of the process, and analyzing the results, and keep abreast of all the latest developments. uh, there are four sources of error: quality of equipment, data acquisition and analysis, calculations, and surgical technique. Now we are going to concentrate on these two only here. Now, going to data acquisition, calibrate. Every day you have to calibrate in the beginning of the day any instrument which you are going to use. And if there is a period of lull, like you are not taken reading for say 1 hour, the instrument has to be calibrated again. Now, for proper technique and training, we have developed such
This
videos.
video demonstrates how to take an image on the Varion image guided system. Patient's name, age, date of birth, and the ID is entered. Before starting taking the reading, make sure that the optical biometry is done. No previous contact method should have been done on the eye. Eye should be non-dilated and no eye drop should have been put in the eye. To start, make sure that the patient's chin is placed deep inside the chin rest and ask the patient to look straight at the red fixation target. At all times, the head of the patient should be straight. The head should never be tilted. If the head is tilted, then the eye image will not be reliable. The canthus should always match the black mark on the sidebar. The forehead should touch the headrest. Ensure that the both eyes are at the same level by moving the joystick from right to left. If they are not,
and the patient has to keep on blinking every 5 seconds, and you take the reading before the tear breaks up. So we should know the tear breakup time of a patient. If it is 5 seconds, you better take the reading before that.
This video demonstrates how to take an image on
and we are all aware that whenever we are taught anything, after 1 month out of that we have forgotten one point, and after 6 months we have forgotten everything, and we are back to square one. And therefore it's very important that we keep on this updating or training sessions again and again. Then the next point is validate. On Warren's website, this validation guidelines for each and every instrument is available, are available, and we must go through them, and we should know which reading needs to be checked again and again. Then we come to the checkpoints. Now there are many checkpoints. What is the signal strength, whether the beam is passing to the macula, what is the standard deviation, whether there are any exclamation marks, etc. It differs from patient to patient. The instrument to instrument, and we use IL Master 700. So these are some of the checkpoints here. Very important that you see this carefully, not just look at the printout. Then attention to details. Okay, I had taken this slide from Dr. Warren's presentation. You can see that there are two dots missing over here. This patient presented with a 1.25 cylinder on keratometry, and he had dryness. When it was treated, these 2 points, LED points, reappeared, and the patient had zero astigmatism. Then fine tuning or optimization. This is perhaps the most important thing. Whether it is Barrett formula or whatever we are using, we know every day nowadays that Barrett is like gold standard, but we still need to optimize to our method. Whatever you do, you have to keep on checking your result post-operatively, understand, exclude those cases where your surgery was not up to the mark, and check post-op refraction 1 month after surgery. And for finding, divide the cases into whether it's a one-off case or a series of cases. Then we come to the 10 commandments of keratometry. Topography will have a separate slide. Topography will have a separate slide. Then calibrate operator's refractive error. This is one instrument where operator has a small cylinder. It will create havoc for us. Untouched eye, point very well covered by Dr. Vipul, and refractive index of 1.3375. I'll come to these question marks again, and correct technique we already seen the video. Then we have to use 3 keratometers preferably, and we have to get 3 similar readings on each of the instruments, and then take one of that, and just such 3 readings have to be compared. We need to understand what is static versus dynamic keratometry. Only the manual is the static one and all others are dynamic, and whenever we are having trouble finding how much the cylinder has, best is to fall back on static keratometry. Then validate matching. I'll come to this point in the next slide. And then we have to develop protocol for special situations like one-eyed patient, squint and MatCat, etc. So what we do at our center is that we got 3 readings, right, from 3 keratometers. If all the readings, the cylinders are within 0.1 diopters and the axis is within 5 degrees, we call it grade 2 matching. You can use any cylinder. If it is between 0.1 to 0.25 and the axis is between 5 to 10 degrees, then we use Barrett's median K or integrated K, and Barrett will tell us, give us a ready-made solution what case to use. And then if nothing is matching, helter-skelter situation, go for manual keratometry. Topography already explained very well by previous speaker, so I will not concentrate on that. Only for biometry, these 3 are important. Look at only the center on axial curvature. Look for regularity and astigmatism. So for corneal power, we will take the power from astigmatism. We'll take the power from the keratometer, which has got the smallest circle. That is the most reliable. And for axis, we will take it from topography, and that also 5 millimeter circle. Then axial length, again there are many criteria for validation, and it is very difficult to explain in a single lecture because there are many instruments. So the most important thing is training. This is, for example, an ideal example of how the B scan can be, A scan can be. Then we go to calculations. The first 3 are already been covered by Dr. Rajendra Prasad, so I will directly go to IOL formulae. See, there is no point in going into theory of how the IOL formulae work. Let us see what are the best practices. So preferably what I do in a normal eye, we use SRKT optimize with Bangkok adjustment and Barrett and Hill RBF, and compare whatever the IOL power is. SRKT is good old one, but optimize and Bangkok adjustment, it works really well, except for short eyes when the axial length is less than 20 millimeters. Then I rely on Hoffer Q. And then new formulae are coming. Barrett suit, everybody is aware of. It's the gold standard. And EVO and Kane, these are the very good formulae now. Statistically, EVO is the best. Okay, and better to use 3 formula for comparison, and all of them are freely available. It helps you in fine tuning, especially you are doing multifocal IOL or trifocal IOL. It will use you can use them for monomicrovision. That means you have done one eye, and after 8 days you do refraction. Patient is left with plus 0.5. They name for minus 0.5 in the other eye. That also increases the depth of focus, and patient's complaint actually decrease. So this is the best practice. To use 3 formulae and from different approaches. That means SRKT is versions, and Barrett is like a kind of semi versions, and then artificial intelligence like Hill RBF, or I will replace it with EVO. Then biometry in special situations. Here we have 2 considerations: whether the cornea is normal or abnormal. Normal cornea, long eyes, short eyes. Long eyes, there are 2 problems. Number 1, it has got long vitreous body, so it underestimates the IOL power. Therefore, Bangkok adjustment has to be done. And second thing is that sometimes in the posterior staphyloma, the fovea is on the slope, and what we get is anatomical axial length, but what we are interested in, functional axial length. So all those equipments with fixation, taking into account, being taken into account, they are more important for that. So solution is optical biometry with visualization of the foveal pit. Then extreme myopia. So what are the best practices? Use universal 2 or heel airbag. This is my, like, I use only 2. Then both do not require Bangkok adjustment. If it is out of bounds, then only SRKT or others can be used. Aim for undercorrection. Over here, there are 2 approaches. Typically, a patient who has been using -12, -14 number, it is better to leave behind -2. So it acts as a telescopic lens if there is a macular problem, and he is used to minus lenses. Suddenly you're shifting him to plus, it becomes a problem. But if the patient is a contact lens user for whole his life, then treat him like a normal case, and then I'll be aiming for, say, -0.5 only. In hypermetropia, the challenges are much more, and our accuracy comes down quite a lot. It's a thicker natural lens. All the dimensions are smaller. A small error in measurements causes big error in. Can I continue? Yeah, I'll finish in 2 minutes. So hypermetropia, the challenges are more, and you see this table will explain to you that entire range. EVO is, and Hill, Arbep and Barrett, they are going neck to neck. Okay, but when it comes to long eyes, the EVO is going better, and when it comes to short eyes, all of them come significantly down. So hypermetropia is still a challenge. Then we come to abnormal cornea, post-refractive surgery, and corneal ectasia. Post-refractive, over here we got 2 approaches. Either you go by the old versions formula. So Goldstrand model, cornea is like a single plane, and the refractive index used to be 1.3375. Over here, we use either Hyggesell, Barrett-Truque, or EKR. And second approach is using new formulae, where the cornea is considered as a biplanar. You use the true refractive index of the cornea, and the examples are Barrett-Truque, TK, and ray tracing. All these formula are available, very easily available, not to worry about it. So I will just go through this fast. EKR is the example I wanted to give for the first approach, where you use the refractive index of 1.3375. And this is the accuracy post LASIK. Myopic LASIK, you see it's an excellent accuracy, but for RK, unfortunately, we don't have such an accuracy. So best practices is calculate IOL power by multiple methods, take average bias towards Barrett. Okay, this is very, very important point, and aim for undercorrection. This is an example of MS39 being used for ray tracing formula. Now the last point is biometry for abnormal cornea, corneal ectasia. Now for that, the first point is that we need to classify the keratoconus or ectasia according to Retis classification, because it takes into account lot of factors, and which are very, very relevant. So decide on toricity first. If the central 3 mm has having regular astigmatism, then go for toricity, otherwise don't. The second point is, if feasible, smoothing procedure has to be done, and then after 6 months we can go for cataract surgery. So topo-guided PRK is the most favorite nowadays. And then for grade 1 and 2 we can use EKR, or that 2 approaches I told you, use any of them. If it is for grade 3 and above, then there are novel methods like smoothing and CEOZ, central effective optical zone. I don't have time to explain, but it's a very good method. And if the keratoconus is far advanced, most of the times people are very happy with the vision, and therefore it is better to go for conservative and aim for spherical IOL and put a contact lens on top, maybe normal contact lens or a scleral contact lens. So it is very important to take into account what the patient perception about his vision is. So my take-home message: acknowledge and live up to the role of the surgeon, decrease variability, analyze the process and the results by paying attention to minute details, and keep updated. Thank you.
Thank you, sir. That was a wonderful talk, extremely relevant. Now the next speaker would be Dr. Vinod Kumar Arora, sir. He needs no introduction. He's been doing this course on cataract surgery, target Emmetropia since many years, and this is one of the most welcome course by the delegates, and it's always one of the most popular courses because it covers everything what a cataract surgeon need in today's era. So he'll be talking about refractive surprise management following cataract surgery. Meanwhile, anyone has any questions for the previous speakers?
I think Dr. Wabekar has made a very clear point that you have to do first you have to calibrate your instruments. That's very, very important. See, many of us have very good of instruments. We both have instruments, but we don't do it regular calibration. So that is very, very important. Even if you are using a basic chronometer, for every session you have to calibrate it. And for most of the instruments require calibration repeatedly. That improves your result. Secondly, if you think there is a doubt, suppose you're getting different readings. So what to do is, suppose your axis is coming 30 in one instrument, 40 in second instruments. So which one to take? I think it's made very clear that topography is the most important. If you're seeing two dumbbells there like shape, you can just hemisect it. And that gives you accurate axis. Not the axis which has been shown by topographer, but you can hemisect that those double shape. That can give you the fair idea where the axis is. So that gives you the degree. For getting a degree, axis is more, topography is more important. For getting a volume of a cylindrical number, I think your autoref or those things are more important. So coming to my talk, you did everything well. Go to refractive surprise top. Go to last. You tried and use your best of instruments, best of technology, and you think everything is going to be okay. But it's not always. You get a surprise. That's the nature of eye. It cannot be purely mechanical thing, and surprises are always there. It's better to be prepared for surprise and how to manage these conditions. So just to recall, the risk patients are small hyperopic eyes, large myopic eyes. There is a big bag. You don't know where the lens will be there. Very steep or flat K, suppose you're getting 49 or 41, 42 like. So you have to be a little cautious on these cases. If there is a shallow anterior chamber, if there is a prior history of refractive surgery, that is coming in a big way. Now we are getting a lot of patients who are going under LASIK. Earlier it was RK, now LASIK. So we are going to get a good number of these patients turning into cataract in coming futures. So we have to be ready for those. Then there's the victimized eyes. Then corneal Lactasia may be there in these cases, like keratoconus or post-LASIK surgery. Then contact lens use. That's very important. We have to just give a sufficient time before taking a reading. For soft contact lenses, at least 3 to 4 days. For GP lenses, 3 weeks to 3 months, you have to postpone the surgery, then take your calculations. Otherwise, there will be corneal warpage, you'll get a wrong reading. So, what are the causes of ametropia? If we say it's not emmetropia, so there is a data capture inaccuracy may be there. There may be preoperative ocular surface disease, which has been highlighted. Then dry eye disease, anterior basement membrane dystrophy may be there. IOL miscalculation may be there. There may be residual refractive astigmatism or post-operative shift in position of IOL. Your IOL may shift. So what are the reasons of refractive surprises? We know there is a limitation of precision accuracy of biometric measurements. It's not very perfect. It's very good, almost close to that one. Then inherent uncertainty of IOL power collection to find effective lens position. So if we make a small error like corneal radius, we get a surprise, big surprise. Then axial length measurement, if it's taken little wrong. Suppose we are using immersion, patient is looking directly over it. So we may get an area in the fovea. Now, it's not exactly on the fovea, it may be in the macula. So we may get a little wrong on that condition. Then post-operative AC depth is there. If there is any wrong calculation, again it may change. And the IOL power calculation, if we put a wrong power, that may give us a surprise. So coming to the back, if everything is done very well, and we believe nothing can go wrong, but we always know things can go wrong. So what to do? First thing is to determine what went wrong. Whether it was a right patient, there are two patients with Ramlal and Ram Singh. And suppose similar names, and they changed, your OT staff had changed it. You're not aware of it. Whether it was the right eye, patient has cataract in both eyes, and you opted for right eye, and patient decides, no, I'll do for left eye. It happened. So you have to be cautious that it's the same eye or what's viewing the other eye. So it's a good practice to mark it before starting your surgery or sending the patient in it. So there are different methods you can use it. Then the right IOL. Suppose you have did a calculation for techniques IOL and it was not in your inventory. Your staff has given you whole IOL of the same power. You'll get a surprise. So you have to look out for what went wrong. And if there is some problem like capsular block is there, that because forward movement of the lens and myopic shift, that's very easy to treat. Just give a YAG capsulotomy nix on the capsule margin. It will take care of myopic shift. And if there is a pure mixed astigmatism, that is plus minus cylinder is there, then we can perform peripheral corneal relaxing incision. I'll come to that also. So coming to the management of refractive surprise, there are various methods. First is the prescription of spectacles. If your patient is happy with the spectacles, don't do anything. Don't try to beat it. Don't try to correct it. He's happy, that it's okay. We want that only. Then contact lenses may not be very good for elderly patient, but young patient adopts it well. Corneal surgery, we can do LRI, especially good for hyperopic astigmatism, or we can do laser vision correction. Then comes the IOL exchange or rotation of toric IOL. I'll not go on toric one, but you can rotate it well. It was discussed, the best time to rotate is after 1 week. Don't rotate immediately, otherwise it may rotate again. So once there is a small fibrosis there, then there are more chances that lens will be stay there. So piggyback IOL implantation like IOL, ICL or even IPCL. Incisional surgery is quite good. You can make a 4 mid-peripheral incision. We take an optical of 3.5 millimeter. It can correct up to low myopia, say -2, and it's very quick and economical. Only thing you require a micrometer with this one. It's not very precise, but it can reduce the load. And it causes glare in few patients. So incisional surgery, that is LRI again. It's good for residual cylinder. If your cylinder is in plus, like +1, +3, then you are going to correct both the things. Your spherical correction also will be there. Your cylindrical will be corrected. If it's a +-1, it will be plano, but some error will be there. Cylindrical number will be over. If you look at a pure cylinder, I think laser is a better choice than doing LRA because of the coupling effect. You will get a surprise on the spherical power. So this is how you see on the notebook. There you can just fill up that and you can see how much arcuate incision you have to make, the amount of arcuate incision, whereas it has to be placed, that will be done over that. So coming to the laser, it's a good choice in majority of the cases. It can take care of all the errors. It's very avoids intraocular surgery. There is a quick recovery. Can correct any residual error. But the problem is this IOL causes some higher order aberrations. LASIK again adds to higher order aberrations. Then it can be dry eye because most of the patients are elderly. And it's irreversible and it may not be available to all the person. So what are the tips if you want to do laser? If you see a patient where you want to put a premium IOL, but you are sure that you are going to get surprise, so pre-surgery flap can be made, preferably by a femto. The tip here is don't lift the flap. Even if you are making with the microchrome or with a femto, just don't lift because most of the complication occurs when you lift the flap. Don't lift. Wait for 1 month. Do the cataract surgery. I would say do the surgery and if there is any error, you can correct it. But it's not very popular because most of the time we don't do surgery in those cases. But coming to the post-surgery, if you have to wait till the refraction stabilizes. For phaco patient, wait for 1 month. For a small incision cataract surgery, you have to wait even longer. Once the refraction stabilizes, then do the surgery. Femto is preferred in these cases. For smaller errors, advanced surface ablation is again very good choice. And transepithelial PRK is preferred in these patients. We have to remember that dry eye is more common in elderly patients. So we have to use a lot of visco in these lubricants in these cases. And these are stiff cornea, especially the elder one. So we don't require mitomycin in these cases. IOL exchange is a choice, not the first one, but of course, if you have to do, you have to do it. So you have to use a lot of viscoelastic. You just dislodge the lens haptics from inside. Only thing you have to use a quite good quality and plenty of viscoelastic. And if you see you can't take out the haptics, it's quite fixed in it. You can just cut the haptics and take out the IOL part only. And then you can place the lens in the sulcus also. So it's not necessary always to take out the haptics part also. So IOL exchange, avoid as far as possible. Verify the problem. It's irregular astigmatism or anything which is causing it. If required, do it earlier, preferably 1 to 2 months before the fibrosis take place. Use plenty of viscoelastic. You can take optics if haptics is stuck there. So disadvantages are difficult to remove IOL in some cases. May cause trauma to rhexis, bag or surrounding structure, or it may cause astigmatism because of forceful extraction or if you are enlarging the incision. But don't hesitate to enlarge your incision if you find any problem. That's much safer than struggling with the lens to take it out. Implantation of phakic IOL, it may be ICL, IPCL, there is a wide range. It retains the corneal sphericity. There is no regression. It's expensive, but long-term effects are not known, and it can be easily retried back if anything goes wrong. So coming to the piggy bank, there is a hyperopia, there is a better outcome than laser vision correction because you don't produce aberrations. Piggyback IOLs have shown to be more accurate than IOLs. Insurance covers lens, so you can probably do it in many patients. So complications which were earlier, interlenticular membrane, pseudoexfoliation, pigment dispersion, corneal endothelial cell decomposition, these were the earlier complications. But with newer variety, we don't get these type of complications. So these are very good lenses. Sulcoflex is one. It's for residual emmetropia. This is about the details. I'll not go in technical details. But we have got a surgical procedure very simple. We just make a small incision around 2.75 and we put a lot of OBD and position the IOL in the sulcus. So it's very, very safe because the IOL there is already in the back. You got a good scaffold there. The power calculation is again very easy. You don't require any corneal keratometry or anything. It depends on the spherical, refraction of the lens. So if there is a myopic correction, whatever you getting on specs, suppose the patient is have correction of around 2 diopter, you can just put a 2 diopter lens. That's easy. For hyperopic correction, you have to multiply by 1.5. Or you can send the data to your company, they will send you the lens. So it's very easy, does not depend on anything else except the refractory error. I think it's a very easy procedure. I do not show full video here. Just routine surgery, put the lens, slide into the sulcus. That's the only thing. Only thing, your earlier lens has to be in the back. So we have got a multifocal, we have got a trifocal lens in this. Then we have got a toric lens also. We have multifocal toric also. This is the Indian version. It's much cheaper and results are very good. You can use this one. This is from Care Group and very, very easy to use and easy to calculate also. And if anything goes wrong, you can take it out easily also. So it's safe, reversible, less trauma than IOL exchange, biocompatible additive implant. Post-op refraction is high predictability is there because we are not taking other factors except the refraction. It's a very simple calculation. It's a reversible procedure explanting at any time it's different to laser treatment, which is irreversible. So specific indication are monofocal IOL. If you want to make it multifocal, you just put a lens over it. Suppose patient has monofocal in one eye, you implant the multifocal in other eye. Now he wants to have the same in the first eye. You can just put a add-on lens on that one. That will take care of the multifocality. Then, just 1 second. A specific condition, you can treat dysphotopsia also. Dysphotopsia is nowadays is a problem. A patient is not recovering after a few months, then you can put this lens. The negative points are the lack of peer review publication. Of course, we got now a lot of publication. Rotational stability is a little lower in this case. So just to conclude, there are a variety of options. We can do IOL exchange, we can do laser vision correction, we can do piggyback. For myopia, laser is preferred. For hypermetropia, because of the aberrations, we prefer piggyback or IOL exchange. For astigmatism, we can do piggyback, we can do laser vision correction, or we can do LRI. So we got a lot of variety options and we can take care of most of the refractive surprises. Thank you very much. So having said this, if you did very good refractive cataract surgery, your results are perfect, 6 by 6 and by 6. But patient, again I told you, maja nahi aaya wali baat. Then what to do? Patient is not happy. So let us see why he is not happy.
A very good evening to all. At the outset, I would like to thank AIS and Vinod Arora sir for having me here. It's been almost a lot of, I think, 3 or 4 years I have been a part of this course. So I would like to thank you for it. So as my previous speakers have mentioned that, if they've done a perfect pre-op evaluation, chosen the right lens, the best lens possible, done a thorough biometry, given options of recorrections if possible. But in spite of all this, there are a lot of times when patients are still unhappy. It's like when they say, I do not see anything, we say, I also cannot see anything. It's just that condition. So what to do in this situation? We, of course, this has been done before, but again, we have to start again from detailed history taking and slit lamp examinations. A lot of times patients have forgotten to tell us something, and we don't know what to do. Again, take a thorough history, especially of any systemic allergy, systemic illness, any previous eye disease, or what is the systemic condition. It's very important to take the history once again, and try to do a squint evaluation. In elderly patients, if it's not thoroughly visible, we probably wouldn't even think of doing a squint evaluation. So do a thorough squint evaluation, even if it looks like orthophoric. Whenever you're dealing with a unhappy patient, after the detailed history, you will go to check the tearful. You can do a dry evaluation, but more than dry evaluation, in this kind of patients, you would like to see the T-butt. And if you have any other dry eye tool, you would like to see that. This is just an example of a OCAS image. If you can see this dot, this is the OSI, the ocular scatter index. Sharper it is, better the quality of vision it is, and more it spreads, it means the quality of vision is poor. So this information you can get from a simple T-butt, or seeing if there are a lot of meibomian secretions present on the ocular surface. That means a patient has a ocular surface disorder, and in elderly patients you see a lot of it. It is a sign of subclinical inflammation, and post-surgery it will just aggravate. Pre-surgery it will not be there, but post-surgery it can just aggravate. Intra-op parameters, or if not kept properly also, it can aggravate. And that's why the patients will have a poor quality of vision. So that's why you see the tear film to begin with. If you have a meibographer, please try to do a meibography, because meibomian gland dysfunction or dry disease is one of the most leading cause of unhappy cataract surgery patients. It's like chubta hai, khuchta hai. That all are the major complaints you see in these dry eye patients. And when you do a meibography, you'll definitely find that there are some abnormal glands present. You do not need to have a meibographer in your practice. Even if you have an autorefractometer, it's an infrared light principle. You just invert your lids, and you can see the meibomian gland health, and if required, you can treat it. Why? Because if the meibomian gland health is also abnormal, it can have a poor quality of vision post surgery, which will be aggravated, and patients might have a higher discomfort. And the third is the epithelium. Now, you've not touched the epithelium in cataract surgery, but you've definitely made a wound, and post-refractive surgery, there is going to be some amount of epithelial remodeling. So that is why it's very important. If you do not see anything, if your dry eye is also normal, if your topographies are also normal, patient is plano, but the quality of vision is poor, try to get an epithelial map done. I'll tell you why. Because we look at the topography to decide whether to go ahead with the surgery or not. But this is just an example, similar looking topographies, but pre-surgery the patient had an irregular epithelium. We do not need to check it for all patients, and we went ahead and did a cataract surgery. Post-surgery patient's epithelium remodeling was aggressive, it was not optimal, and he landed up in a cylinder of minus 1.17. He was not accepting the cylinder because it was coming from the epithelium and not from the other optical zone. So that is why whenever the patient is unhappy, poor cataract surgery which is aggravated, please, and if you can't find anything, try to get an epithelial mapping done, because abnormal epithelium can also be a cause of poor quality of vision, glare halos, and discomfort, and like glary vision. So that is why it's important to see that as well. Topography, of course, we do not need to do it for all our refractive surgery, cataract surgery patients before surgery. But if it's a normal patient, where you've done a monofocal lens, you do not need to do it, and your biometer will not tell you what it is. But post surgery, for any reasons, patient is unhappy, try to get a topography done, because keratometry is always can be normal, but there can be subtle signs of keratoconus or something underlying, which can also have a poor optical quality and poor quality of vision post surgery. That is why I also do a topography post if the patient is unhappy, to rule the same out. The second would be the pupil size and aberration. My previous speakers have, of course, spoken about it very well. But again, if the tear film quality is bad, or if the healing has not happened properly, post surgery patients can have higher order aberrations on the cornea. You can get it from any machines you have. Your normal topographer will also give you information on the higher order aberrations. And higher order aberrations being on the higher side, more than 0.5, can also be a reason of poor quality of vision. So rule that out as well. Angles. Now, angles here, I'm not talking about the gonioscopy angles and the glaucoma ones, but if you have a perfect tear film, if you have a perfect topography, if you have done a perfect biometry, a perfect surgery, but the patient is still unhappy, what is the missing link? What is this, like, what is missing in this puzzle? This is just a basic of how your pupil centration and how the centration of the optical, the light is. And this is the center of the limbus, this is the center of the visual axis, and this is the center of pupil. They should be aligned together. But if the angular distance between the visual axis and the pupillary axis, which is known as angle kappa, and the angular distance between the optical axis and the visual axis, which is known as angle alpha, are abnormal, more than 0.5, then also the patient post surgery can have a poor quality of vision. Everything is normal, but if these optical visual axis, pupillary axis, and optical axis are not in alignment, then also they can have an unfavorable outcome and poor quality of vision. So rule that out as well. And this is just one of the examples. This is a normal angle alpha, large angle alpha. Post surgery, even though the IOL is well centered, patient will be unhappy. And last but not the least, a lot of times, a premium IOL patient, I'm not talking about monofocal IOL patient, but premium IOL patient, especially the EDOF lenses and the multifocal lenses, we have explained them about the neuroadaptation time. But still, sometimes beyond the neuroadaptation time, also they come and complain to us that I have constant glare, halos, and the symptoms are not going away at all. The lens is well centered, everything is fine, but still the patients have complained. These patients are above 40 years, they have lost their accommodation, natural accommodation, but still they have some muscles in them which can lead to divergence or convergence insufficiency or excess, and that's when also the patients can have glare and halos. So it's very important for us to do a orthoptic evaluation when you have ruled out everything but you cannot find the answer. And if there is an orthoptic imbalance which is present, then you treat the patients with orthoptic exercises, and believe me, the patients do quite well because the neuroadaptation increases quite a lot. So that is why it's extremely important to rule that out as well. And nonetheless, everything done, sorted out, ruled out, if the patient still are unhappy, of course the answer lies in personality. Patients might not tell that okay, they have a personality issue, but you can always, it's a freely available questionnaire, icing personality questionnaire. Just ask them to fill the questionnaire, and it will give you information whether the personality is normal or abnormal. If the patient is melancholic or choleric, that means it's a red flag sign, it's an abnormal personality. They are aggressive, restless, anxious, and always dissatisfied. So you cannot do anything in it. Very nicely, you can take the family in confidence, and you can refer to them to a psychologist for a counseling and see if you can improve that or not, because that is not your surgery, that's just their mindset. So a very easy way to rule out is a personality questionnaire, because they will not tell them that I have a problem. So you need a proof, right? So this is the way. So just to summarize, rule out any dry eye issues, rule out any epithelial related issues when your patient is unhappy, rule out any suspect topographies, the angles, and if nothing works, rule out the orthoptics and the personality related issues. Thank you.
Thank you very much, Dr. Pooja, for making it such a elaborate of every aspects of surgery or of unhappy patients. We got this session a little late, but we tried to finish in time. Thank you so much for everyone. I think the next one are waiting for us. So we are leaving the session. Thank you so much.